Good evening, Abha ma'am. Good evening, Trapti ma'am. I would take this opportunity to convey my regards to you, ma'am.
Hello, Dr. Sarita.
Dr. Asha
Namaste,
Didi.
ma'am.
Namaste and welcome all.
So we are at 6 o'clock,
Yes.
sir.
So we should start.
Namaste, ma'am.
नमस्ते नमस्ते सॉरी मैं अपना चश्मा ढूंढ रही हूँ बहुत देर से मिल नहीं रहा है एनीवे इवनिंग मैम
Mr. Shah, you may start, please.
You're looking nice without chashma.
पता नहीं
Hello.
कहाँ रख दिया बहुत देर से ढूंढ रही हूँ हेलो एवरीबॉडी आई कैन सी तृप्ति मैडम नमस्कार
ma'am.
पटेल सर
Yes, namaskar, madam.
आशा गुड इवनिंग
मैम मैंने पहले ही नमस्ते किया आपको.
हाँ नहीं मैं ना चश्मा ढूंढने दूसरे रूम में थी ऑन करके चली गई थी
नमस्ते मैम.
नमस्ते ज्योति
गुड इवनिंग मैम.
गुड इवनिंग प्रकृति
Namaste, ma'am. And namaste, Patel sir. आपको बोला but
Namaste,
आपने सुना
namaste.
नहीं.
नमस्ते संगीता
Welcome.
Namaste, ma'am.
हेलो मैम. संगीता मैम. दोनों संगीता.
Hi, good evening.
सरिता मैम. हेलो.
सरिता दीदी
Hello, Sangeeta.
Hi.
Dr. Sinha. You are muted.
Namaste Sangeeta madam.
Hi, ma'am. Good evening. I'm at the airport.
Start कर दीजिए प्लीज. प्रोग्राम को स्टार्ट करिए.
I have sent it to you, ma'am, on WhatsApp.
All right, checking. Okay.
Okay. Can we start, ma'am?
Oh yes, we can.
Good evening, respected delegates and faculties. On the behalf of Corona Remedies, I am Tirth Shah. Welcome you all in 170th edition of Happy Learning Masterclass webinar series in association with Bhilai, Bilaspur, Raipur, Katni, Rewa, Sagar and Sinugri. And the theme of today's webinar is Mixed Bag. And the convener of the today's webinar is Dr. Asha Jain. Slide is visible to all of you?
Yes.
Yes.
Okay. So Dr. Asha Jain has a 32 years of experience and she is a Foxy recognized center of ultrasound training center and colposcopy training center. Dr. Asha Jain is currently director of SMSA Hospital Raipur, medical director Cancer Prevention and Relief Society. She is an elected member of CG Medical Council and she is the vice president of IMA Chhattisgarh. And the current interest of Dr. Asha Jain is in saving the uterus, fetal medicine, obscene gynecology ultrasound.
This is my own society, dear. Leave it.
Sorry, ma'am.
You can leave this. We should go further.
Okay. So we will start our session with our tradition, that is for digital light lamp. So I want to join all of you in this digital session. Now I will hand over this session to Dr. Asha Jain. Asha Jain, ma'am, over to you.
Thank you. Would you please stop sharing?
Yes, ma'am.
Namaskar and welcome on behalf of Happy Masterclass. The program director is Dr. MC Patel, sir, and this is his brainchild, and he has made it reach 170 edition this time. So, sir, he is here with us and he will be giving the official welcome address to all the faculties. So over to you, MC, sir.
Thank you, Dr. Asha. It gives me immense pleasure to welcome you all on 170th episode of Happy Learning Masterclass Web Series. And as mentioned prior also, all the society who has joined this webinar, Bhilai, Bilaspur, Raipur, Katni, Rewa, Sagar, and Singrauli. So I welcome Dr. Abha Singh Madam, who has kindly consented to be chief guest to bless the webinar. Of course, she is always with us in any of our academic activity. And I am always blessed with her blessing also as far as any of my academic activity is concerned. So welcome Dr. Abha Singh Madam. I also welcome Dr. Tripti Nagaria Madam. She has also kindly consented to be guest of honor to bless the webinar. Of course, she is also with us in any of our academic activity. I also welcome Dr. Sarita Agarwal Madam, one more guest of honor to bless the webinar. She has also kindly consented to be guest of honor. I also welcome learned speaker for today's webinar, Dr. Binu Kushwaha, old good friend. She is going to discuss very interesting topic for today's webinar, that is inverted pyramid as far as antenatal care is concerned. And to chair that very prestigious talk, I welcome Dr. Jyoti Jaiswal Madam from Raipur, Dr. Sangeeta Sharma Madam from Bilaspur, and Dr. Sangeeta Sinha Madam from Bhilai. And we are going to have very interesting panel, and that is the reverse panel on PCPNDT Act. And in reverse panel, panelists will be asking questions, and being a moderator, I will be answering all the questions to solve the query. So I invite all the panelists, Dr. Nidhi Bajaj Madam from Katni, Dr. Vanda Gupta Madam from Katni, Dr. Padma Shukla Madam from Rewa, Dr. Rekha Singhal Madam from Rewa, Dr. Tabassum Dalla from Raipur, Dr. Monica Pathak Madam from Raipur, Dr. Rasmi Sharma from Bilaspur, Dr. Kirti Kovra Madam from Bhilai, Dr. Jagruti Nagar Madam from Sagar, Dr. Taruna Sharma Madam from Sagar, Dr. Mahesh Prasad from Singrauli, Dr. Prerna Shukla Madam from Bilaspur, Dr. Prakruti Verma from Bilaspur, Dr. Rasmi Budhia from Bilaspur. And I also welcome Dr. Asha Jain, who is convener for not only for today's webinar, but since long in this series as a convener. I welcome Dr. Asha Jain. I also welcome Dr. Rekha Rajendra Kumar. She is coordinator not for today's program, but she is coordinator since long in this series. So this is our fourth round with all this society of Chhattisgarh and few societies of MP. So in era of COVID-19, when I started this series with 3 friends, and now it has extended to 7,000 plus member as far as this Happy Learning Masterclass web series family is concerned, to discuss focus topic and to be updated with knowledge for that very particular topic. And ultimate goal was to be helpful to our patient in our day-to-day practice to check maternal mortality and infant mortality. And at the same time, not to end up into any kind of litigation was also one of the goal of this series. So we have kept one medical legal topic every time. And with this fourth series, it is fourth round with all the Society of Foxy. We have completed already 3 rounds. And in fourth round, now we have started reverse panel as far as medical legal topics are concerned. And today we are going to have discussion on PCPNDT Act. It was demand from Chhattisgarh and this Society of MP that we want to discuss PCPNDT Act in this series. So we have kept this topic, and all the panelists are open to ask any question related to PCPNDT Act. And at the end, when all the panelists have asked their question and query, any delegates who is having any question related to PCPNDT Act, we will be happy to answer that question also. So with this background and welcoming you all the president and secretary of respective society who have joined this webinar and all the delegates who have joined this webinar. Thank you very much.
Thank you, sir. May I have the CV of our chief guest, Abha Singh ma'am?
Tirth.
I think it's okay, Asha.
Yes, ma'am. Yes, ma'am.
Ma'am, it will have to be displayed, ma'am. It's protocol. And this will be recorded for everyone to see. So please share ma'am's CV.
Of course, it is with Chhattisgarh and few society of MP, but it is being relayed all over India and in Facebook also. So there are so many delegates from other states also, and for that there should be some description about CV.
Mr. Tirth,
Yes, ma'am.
is it possible?
Please display the CV.
I think it's okay, Asha. We can just go ahead with the program.
So I
Yes,
would
I'm
like to
sharing this.
introduce our chief guest for the evening, Dr. Abha Singh ma'am. She is Abha
Previous
Singh
one.
ma'am.
Previous one.
She is. She was the VC of Ayush University, Dean of Medical College, and more than that, she has been a mentor for almost every gynecologist, especially the younger generation that is practicing in Chhattisgarh and around. Also, she's the one who has actually activated most of the societies. Raipur Obstetric Gynae Society was the oldest society which was existing before, but everything else, IMS, ESAR, IFS, ISOPAB, madam has been instrumental in getting everything rolling. And she's a very respected figure for all of us. If she's there, we all feel blessed. So ma'am, we would like to hear a few words from you.
Thank you very much, Asha. I think your introduction means a lot to me because you have put such good words for me. First of all, what an auspicious day. Today is Panchami. So wishing everybody a very happy Navratri. Secondly, congratulations to Dr. Patel sir for his persistence, patience, and today is his 170th series of these webinars. So a very long innings, sir, and hats off to you for all these kind of happy learning. I love the heading you have given to it. And Rekha madam has always been there as a coordinator, and Asha is also there, and what a lovely coordination your team always brings. And it is very fortunate for all of us to be part of that team. And as you said, this is the 4th for Chhattisgarh. So I'm very happy to be a part of this very nicely selected topics as always. This is a reversed doctor. She's going to talk about Dr. Binu Kushwaha is going to talk about the reverse pyramid of antenatal care, which is so important these days. And for any medico-legal aspects on anything, I think there is no other man than Dr. MC Patel. He's always there to guide us through the rights and wrongs of every act. So I think I give everybody my best wishes, and thanks for allowing me to be a part of your journey.
Thank you, madam, for sparing time to bless us. Thank you.
Thank you, Abha Singh ma'am. You know, our coordinator, Dr. Rekha Rajendra Kumar, wasn't introduced. So she is a practicing gynecologist for past 31 years. She's a president-elect of Bangalore Obstetric Gynae Society next year. She's an invited faculty in more 700 state, national, and international conferences. South Zone Coordinator, Foxy Infertility Committee, Chairperson Infertility and ART Committee, Kasoga, Chairperson Ethics and Medical Legal Committee, Kasoga, and she has 15 awards, 5 felicitations. She's an ex-PG teacher of MS Ramaiah Medical College, and she has many articles to her credit. So, welcome, ma'am. And I would, if you would please introduce Tripti Didi.
Thank you, Asha Jain madam, for that. Thank you, MC Patel sir, and all the esteemed faculties who are here. We are very happy to have you all here. Happy Navratri. It's my proud task to introduce Madam Professor Dr. Tripti Nagaria, madam. Madam is the Dean Professor of Pandit Jawaharlal Nehru Medical College, Raipur, Founder President of Isopar Raipur, State Secretary of Association of Societies of OBG, past President of Raipur OBG Society, past Secretary of ISAR CG Chapter, IMS Raipur Chapter. Madam has lot of papers and contributed 8 chapters in books. Academically, Madam is very rich, corresponding national editor of Jogi, recipient of Global Signature Award. She is also invited faculty in more than 200 conferences. She has organized important prestigious conferences, including the IMS State Conference, has lot of workshops and CME being conducted under her leadership. Over to you, Tripti madam. We would love to hear from you.
Thank you, ma'am. Thank you for such a nice introduction. First of all, good evening to everyone. And I'm proud to be here along with all the other members to attend this webinar, and you have given me this prestige. Actually, the webinar which is being conducted by you, it is most awaited one. Every time you are bringing up very new topics and very interesting topics, particularly with day-to-day problems, the medical legal one, which Dr. Patel sir always as usual is there to help us out. We have also attended him personally at Raipur, and such a knowledgeable person. So we are actually privileged to have sir with in this all webinar series, which is a very long series of 170. Too long, very, very long, and this itself shows that how popular it is amongst all the gynecologists. So I congratulate sir and all of you, the whole team, for such a wonderful webinar. So thank you so much.
Thank you. Thank you, Tripti madam, for sparing time to bless us. Of course, you are always with us.
Thank you, Tripti madam, for those words. Thank you.
Now, I would like to introduce Professor Dr. Sarita Agrawal, who is our next guest of honor. So, she is Professor and Head Obstetrics and Gynecology, Dean Research, AIIMS Raipur. She has been Vice President Foxy in 2015, ICOG Governing Council Member 2015 to 17, Academic Council Member 2017, and Chairperson HIV Committee Foxy 2010 to 13. She has been invited faculty in more than 150 conferences and CMEs, organizing co-chairperson International Conference on High-Risk Pregnancy 2015, organized 15 basic laparoscopy workshops as VP Foxy 2015, and organized sensitization workshops on HIV/AIDS, about 30 all over the country. She has work of excellence, CG Sachs for service in PMT-CT, Bharat Jyoti Award 2009, Dr. G.P. Srivastava Academic Excellence 2009, MS Signature Awards on Phenomenal Leadership 2020. She has ongoing and approved research with ICMR, and she has been an invited faculty in many international conferences. She is in AIIMS and is actually doing a lot of excellent academic work. So we would like to listen to you, Dr. Sarita. Over to you.
Thank you, Dr. Ashadi, for the kind, elaborative CV. Actually, I don't deserve when Dr. Abha Singh Madam and Dr. Tripti Nagaria Madam and the like Dr. MC Patel are sitting over here. So first of all, I would like to thank Dr. MC Patel for taking me this honor to be as a part of guest of honor in this prestigious master class on happy learning. I can say him the father of this happy learning master series, sir. And Honorable Chief Guest, Dr. Abha Singh Madam, who is an epitome of knowledge. And she's a mentor for everyone. And she's a legend and inspiration for all of us. And same is true for Dr. Tripti Rangania Madam. She's a teacher of teachers. And she's always inspires all of us to do something good in the life. And the coordinator, Dr. Rekha Rajendra Kumar, and I can see the DO Sangeeta Madams, those who are here, and all of the faculties and the dignitaries. It is a proud privilege for me to be here on this auspicious webinar. Happy learning, the name itself makes us happy. And the topic, the invert pyramid, where it demands for the maximum care in the early pregnancy. I think if you do a maximum care in the early pregnancy, you need to care less in the late pregnancy, and you can catch them young, sort of. When you talk about the adolescent health, we can catch the patient early who are risk for developing certain complications. So the very apt topic you have chosen, sir, for this, which every obstetrician should know what the important is. And similarly, the reverse pyramid, reverse panel, it is something in a very innovative concept we all are going to enjoy. Thank you, sir, for choosing all these things. And I must congratulate MC Patel, sir, convener Dr. Asha Didi, for a wonderful webinar. And for MC Patel, sir, I see you as a future Foxy president. So wish you all the best for all this. Thank you so much for inviting me as guest.
So thank you, Dr. Sarita Madam, for sparing time. Of course, we have worked together in Foxy level.
Yes.
And when we were working there, I have seen you working very enthusiastically in those days also. And you are always with us in any of our academic activity. Thank you. Thank you for sparing time.
Thank you, sir.
Welcome.
And thank you, Sarita. Thank you, Abha Singh ma'am, Tripti Didi, Dr. Sarita, for being here with us and actually giving a real academic start to the evening. Now, sir, with due permission, we would start the scientific session.
We can.
So we are well within time and we are going to start the academic session. For that, to introduce our chairpersons, I would request Rekha ma'am, please introduce our chairpersons.
Thank you so much. Welcome again all to the scientific session of today's evening. The first is the talk, the session 1, that is on inverted pyramid of antenatal care. I request the chairpersons. The first chairperson, Dr. Jyoti Jaiswal Madam. Madam is a professor and head of the Department of Obstetrics Gynecology, Pandit Jawaharlal Nehru Medical College, Raipur. President-elect of Raipur OBG Society, Vice President of CG ISAR, Secretary General of Raipur ISOPAR. Madam has a lot of great positions occupied so far, and in recognition of her service to the mankind, Madam is the recipient of many reputed awards also, like Dr. Suvarna Kadilkar Best Committee Award, MS Signature Award, NAICA Award, etc. And a lot of publications to her credit at the international as well as the national forum. That is a very brief CV what I have expressed now. Welcome, Dr. Jyoti Jaiswal Madam.
Thank you. Thank you, Rekha Madam.
Yeah, thank you for chairing the session today. I again request the second chairperson, Dr. Sangeeta Sharma Madam. Madam is a MS, OBG as well as LLB. She's the Vice President of Foxy Bilaspur in 2023 to 25. Senior gynecologist and director of Sharma Hospital, Bilaspur. Madam has contributed various publications in national as well as international journals, contributed chapters as authors in many books, has won award in Yuva Foxy North Zone on thyroid disorders in pregnancy. Madam's area of special interest is in operative gynecology. Welcome you, Sangeeta Madam, to this forum.
Thank you so much, Rekha ma'am. Thank Thank you so
Thank
much.
you
And
so
the
much and
result
welcome
of
once
ethical
again.
work.
Hearty welcome to Dr. Sangeeta Sinha, Madam, to chair the session. Madam's designation is she is the Assistant Reproductive Technology Consultant as well as endoscopic technologist. Madam is the director, Sangeeta Sinha Madam is the director of the Srijan Billai Test Tube Center, which is an ISAR accredited center, Foxy recognized infertility center. Madam is made herself a mark in IMA also. It's an approved center for fellowship course in infertility. She's the president of Foxy of the Billai chapter from 22 to 25, IMA Durg Women's Wing India 2023, as well as IMA AMSCG secretary from 2023 to 25. Over to all the three chairpersons and requesting the chairpersons to take the proceedings forward. Thank you.
Thank you, ma'am, and good evening all. Good evening.
Good evening, everybody. May I go ahead with to introduce Dr. Beenu?
Yes.
Yes,
So,
please.
Professor Beenu Kushwaha is professor and professor in the Department of Obs-Gynae, SSMC Reba, MP. And she is recipient of 5 gold medal and best student awards. So we are going to listen to a very bright student who is professor now, awarded by International Journal of Obs-Gynae for best original research article in year 2009 on medical abortions. So I request Dr. Beenu to present on her talk about the antenatal care, the reverse pyramid.
Thank you, ma'am. Thanks for your kind words of introduction. I'm once again trying to share my presentation. Just a last try. Is it visible now?
No, Dr. Beenu, it's not.
It's not visible, Dr. Beenu. You stop. I will share.
Okay. Sure, ma'am. Sure.
You just stop. I will.
Sure.
Hopefully, I'll do it well, and you won't have to actually say next again.
Oh, thanks for that, ma'am. So at the outset, I would really like to, say thanks to MC Patel sir and Dr. Asha Jain ma'am for involving me in this prestigious series of webinar and giving me this opportunity to speak on such an important topic, that is inverted pyramid of antenatal care. So I would start with the background. So.
Just a second.
Yeah, sure, ma'am.
I will have to close this, only then it will work. Just a second. I have 3 presentations open, so they are not working. All set?
Yeah, Ji ma'am.
To make it full screen.
So can it be made? Yes,
Yes,
ma'am.
yes.
Thank you, ma'am. Thank you so much, ma'am. So as Dr. Sarita madam has also introduced the topic to the audience, that traditionally pregnancy management involves handling with the problems as they appear. And as most of the maternal and fetal complications emerge late in pregnancy, so most of the focus traditionally has been put on 3rd trimester. But with invention of modern modalities in recent times, role of prediction and prevention in the field of obstetrics has evolved in a big way. Especially emergence of 1st trimester USG screening for fetal aneuploidies and later on use of serum markers for the same has laid the foundation for emphasis on screening in early pregnancy. So basically, this inverted pyramid of antenatal care encompasses the screening for possible maternal fetal complications via maternal testing that is done in 1st trimester or in early pregnancy. So we are trying to catch them early so that we can start the preventive measures on time, and we can, in fact, in some conditions, totally prevent the disease altogether. And we are trying to do it in early pregnancy because the sensitivity or the detection rate of certain tests is much higher in first trimester. And if in case some abnormality has been detected in fetus, then the medical termination of pregnancy is much easier in first trimester, and it is less traumatic for the parents as well. But these all tests need to be confirmed by the diagnostic tests. So the concept of inverted pyramid of antenatal care has been introduced by Professor Kypros Nicolaides, who basically is now considered as the father of fetal medicine. So he published his inverted pyramid of antenatal care research in year 2011. And he said that the many of the pregnancy complications can be reliably predicted by a combination of biochemical and biophysical markers that are done at 11 to 14 weeks. So this is the reversal of pyramid of antenatal care. On the left side, we can see that in earlier approach, it was the late second and third trimester where the most of the visits would happen. But nowadays, we say that we try to detect or predict most of the problems in early trimester, and then we do a triage, dividing them into two groups. One group that would need a specialist care. Specialist here means fetal medicine specialist. And the another group would go usual care by a gynecologist. And at around 37 weeks, a birth planning will be made, and by the 41 weeks, the lady would be delivered in a good condition. So what exactly needs to be tested to detect as much as problem in early pregnancy? So this is a basic rule of screening program, that we screen only for the problems which have got high prevalence in masses. So here, these are the problems which we all know are very common in pregnancy, and if they are detected early, then we can intervene on time. So we all know that the anemia is the most common medical disorders of pregnancy. So definitely we need to screen for that. GDM and diabetes, that incidence now in India is up to 20%, India being the diabetic capital of world. Preterm birth up to 15% of incidence, hypertensive disorders of pregnancy up to 10% of incidence, Rh negative pregnancy up to 3 to 5%, then UTI in terms of asymptomatic bacteria or the actual infection, its incidence is up to 25%. And other than these medical problems, we need to predict about the fetal problems as well, that we can now do by the panel of tests that are to be done early in pregnancy. So this is how we turn, if we turn the pyramid of prenatal care, we would be able to predict these many conditions by 12th week of gestation. So if we go one by one into the actual problems and how to detect them, first one would be the fetal problems, and these are the tests available. We can broadly divide these tests into non-genetic and the genetic ones. Non-genetic tests are basically used to predict the medical problems in a pregnant lady. So blood group, CBC, OGCT, viral markers, VDRL, thyroid test, HB electrophoresis and HPLC is only done when we suspect specific thalassemia or sickle cell disease, or when we confront a lady who come from a high prevalence area who has these problems. Then IgG, rubella, HbA1c, thyroid antibodies, these are to be done in specific conditions. Then we have serum markers like serum PAPE and PLGF, which other than the genetic problem can also predict about the problems like FGR and PIH, that is hypertensive disorders in pregnancy. We also do urine routine microscopy in all the ladies. If we talk about the genetic test, that is the probability of genetic problems or chromosomal problems in the fetus, which we do by doing blood test in mother. So for that, we have double markers like serum PAPE and serum free beta SCG, and at higher level we have NIPT, which is cell-free fetal DNA testing through the maternal blood. Nowadays we have first trimester penta screening also, which is PAPE plus SCG, and in addition to that we do PLGF, AFP and DIA. It basically increases the sensitivity of the detection of fetal aneuploidies and also helps to detect the to predict the PIH or hypertensive disorders of pregnancy. But these having all these tests in our hands, the history and the examination is not to be bypassed anywhere in antenatal patients. So this is how this testing protocol has changed over the years. Earlier, our FOXy's protocol was this: when the serum markers would come under the preferable test, and this is how in 2020 everything has changed, that it has come under the essential test. So if we go to the next slide, we would see that there are many tests which were earlier in the category of preferable test have now come under the recommended or essential test. And in year 2020, COVID testing also been added when the COVID era was there. So it has been categorically said that all pregnancies should be offered with serum marker testing. So why do we need to screen for chromosomal anomalies in fetus? There are multiple reasons for that. First is that chromosomal aberrations may occur spontaneously. It is not like that if only the parents is having some problem, then only the baby is going to have that particular genetic problem. No, it is not like that. It can occur spontaneously, and they are relatively common. We might think that they are not that common, but India being a huge populated country, they are common in our country in terms of number of diseased patients. And there is a considerable financial, social, and emotional cost. And we all know that most of the down babies are delivered to women who are less than 35 years. This is one reason. And another reason is that more marriages are now happening beyond 35 years, which is itself considered to be a high risk factors for having fetal aneuploidies. So if we say, is it that common? Then yes, just look at the numbers. How huge is the number of congenital malformations in this country? These figures have been given by Dr. I.C. Verma from Sir Gangaram Hospital, Delhi, who has been recently awarded with Padma Shri, our own father of genetics in India. So this categorically says that it is a huge problem in our country, so it should be tested. Next slide, ma'am, please. So what are the options available for serum screening for chromosomal abnormalities? In first trimester, we have double markers, and at certain places, we have first trimester penta testing also available. But many a times, patient would come to us in second trimester. Then we have moved on from triple markers to quadruple testing now. And recently, second trimester penta testing has also come in, where they have added the hyperglycosylated HCG to increase the sensitivity to detect fetal aneuploidies. Then we have this NIPT also, which can be done after 10 weeks, anytime throughout the pregnancy. But considering the MTP Act, we need to do the MTP before 24 weeks. So we would practically be doing it till 20 weeks, because the report also takes time. It takes at least 7 to 10 days. So we should consider that time also. So what are the prerequisites for this serum screening? They are not the tests which are to be prescribed like blood group and CBC. There is a certain protocol which needs to be followed when we prescribe these tests. So as I said, a good history taking, including age, ethnicity, family history, and examination that includes weight, is very important to correlate with this serum marker testing. Then a dating scan if it is being done early, or otherwise we can do we can use the anti-scan also as a dating scan when we are doing it at 11 to 13 weeks. It also requires viability of fetus, number of fetus, and very important thing that a proper pre-test counseling needs to be done when you are prescribing a serum screening test, because a patient needs to be told that it is not being done for all chromosomal problems. It is only for 5 chromosomes and basically for fetal aneuploidy. It does not mean that if the test is negative, then all the chromosomal abnormalities have been ruled out. No, this counseling is very important, and in that counseling, we also need to tell the patient about the availability of further options. What if the test comes out to be positive? You should be able to be in a condition to tell that if this test come out to be positive, what would be the next step. So this much pre-test counseling needs to be done. We all are familiar with the reports that are given to us, reports of serum marker screening. Serum marker screening, if it is 1:250, more than that, then it is considered to be positive, or less than that, then it is considered to be negative. But then we do not interpret it alone. We always nowadays interpret it in combination with anti-scan, that is known as combined test. Next slide, please, ma'am. So coming to ultrasonography in pregnancy, if I have to say that how many ultrasounds are essential in pregnancy, then in early pregnancy, it is the dating scan and or anti-NB scan. We may need to do these two separately, or we may do it we may do only anti-scan as a dating scan, but that depends on the profile of the patient. If there is a patient who has multiple losses earlier, then we need to do a dating scan, and also to see the viability of the fetus, and then we need to repeat the anti-scan as well. But there may be a patient who is a very low risk, who has come to you at around 10 weeks, then you do not need to do ultrasound, then you only need to do a anti-NB scan. Then another must scan is an anomaly scan, and at around 20 weeks, and then growth scan. Nowadays there has been much emphasis put on the growth scan, which should be done at around 32 weeks. Many international agencies advocate the growth scan doing at 32 weeks. Then additional scan, depending upon the patient's profile, is early anomaly scan, fetal echocardiography, and in last trimester, if you feel like there is a clinically you feel some problem, then you may go for a last trimester USG as well. Then we all know about the anti-NB scan. It is to be done from 11 weeks till 13 weeks, 6 days, with a CRL from 45 mm to 84 mm. This is very important, that your anti-scan has to be very reliable. So you should actually identify one radiologist who is doing a very good anti-NB scan and has been certified from some authority, so that your anti-NB scan becomes reliable. Or even if you are doing your anti-NB scans, please get yourselves certified, because it gives lots of information about the baby. What to look for in an anti-NB scan? In a basic scan, we look for nuchal translucency, presence of nasal bone, dating, and number of fetus. And if there is a multiple gestation, we need to know about the chorionicity. In extended markers, which increases the sensitivity of detection of fetal aneuploidy, and also tell us about the prediction of like IUGR, sudden fetal death, or hypertensive disorders in pregnancy. So for that, we need to add the uterine artery Doppler, tricuspid wall regurgitation, ductus venous pulsation, and basic fetal anatomy. They say a good first trimester anti-scan can rule out up to 90% of fetal malformations if it is done properly. So that can also be added in a high-risk patient. So coming to the next slide, what if anti-scan is abnormal? So just to tell you that it is an isolated marker of fetal anomalies other than the aneuploidies. So if your combined test is abnormal, it is all right. You will be going for the first the screening, then the diagnostic testing for the fetal aneuploidies. But even if the diagnostic test turn out to be negative and NT is high, then it is an isolated marker for fetal anomalies, and you should counsel the patient regarding the development of IUGR or sudden fetal death or cardiac anomalies in ongoing pregnancy, even if the karyotyping is normal. So this is one indication to go for fetal echocardiography at around 22 weeks. So high NT is an indication to refer the patient to a fetal medicine specialist whenever feasible and possible. So how to go about further? If your test, you have done a combined test and it has come, if it has come under the category of high risk, that is more than 1 in 100, then we should straight away go for a diagnostic test ideally, and that in first trimester would be CVS. In certain conditions, patient may request you to go for NIPT. So in a very low risk patient, you may go for a NIPT also in these patients. And Termination, but the termination would only be done on the basis of diagnostic test report, not on the basis of NIPT. NIPT has got a very good negative predictive value. If it is negative, it is fine. But if it is positive, it is not diagnostic. She has to undergo a diagnostic test, that is in first trimester, is chorionic villus sampling. And what if she turns out to be low risk, that is less than 1:1000, then no further testing is required for fetal aneuploidies. She can go ahead with usual antenatal care, but anomaly scan needs to be done at around 20 weeks. But what if the risk comes out to be in between? Then we have nowadays a contingent option, that is to go for NIPT. So we can go for NIPT. If it is negative, then it's fine. If it is positive, then we can go for the diagnostic test. And these are the multiple ways in which we can do, we can combine these tests. We generally, what we follow is a contingent sequential test. That is what the low risk patients are to be left. They will go for usual care. The high risk would go for the diagnostic test, and the intermediate group would go for the NIPT test. And
I think we've
she's-
lost contact with her.
Yes, he has lost connection rather. Some connectivity issue.
Should I call her and see, sir?
Yes, we should. And we can wait for some minutes, no issue. Because many times there could be instability of net, and she may come again back also, no issue.
Till she is being reconnected, sir. What I am saying that she is very systematically explaining about the reverse pyramid of antenatal care, and it is really very important even in the today's scenario, that in the periphery of India, even the first trimester patients are still not coming for proper screening and checkups. They think that in the second trimester and the third trimester, it is more important to get the tetanus injection done and get the delivery. That's it. So this awareness at the level of the city and more at the level of periphery, it is really very important. And Asha Didi, I will congratulate you and sir and Rekha madam that you have brought out this nice lecture, that really it is more important to have the more concentration on the first trimester screening, and always prevention is better than the cure later on for the problems, which we can identify by this reverse antenatal care approach.
Yes.
I have joined in through my mobile,
yes.
sir.
Yes, you can continue, Binu.
Yes. So it is basically the contingent sequential approach that we all follow in our country. Next slide, ma'am. So nowadays we have this NIPT or NIPS test. There is lots of curiosity about this NIPT test, especially among the young obstetrician. They think it is a Pandora box. It can solve everything out. If it is negative, it means everything is negative. Baby is totally fine. So no, it is not like that. First of all, we would start with the thing that what is NIPT? It basically detects the cell-free fetal DNA that is present in mother's blood from 7 to 8 weeks onwards. And so it is not to be done before 8 weeks, and optimum fraction is present only after 10 weeks. So preferably to be done only after 10 weeks. Next, ma'am. So here also there is the role of pre-test counseling and prerequisites. So what all you need to do? Case needs to be reviewed in terms of a thorough history, and before you offer this test to the patient. So the family history is also reviewed here. Baseline ultrasound examination is done. You need to have an anti-scan, or if you are ordering it in second trimester, a target scan can be the option. It only gives you information about 5 chromosomes, and most importantly 21, 18 and 30. Right? So, and it is not a diagnostic test, but a high efficiency screening test. So if it turns out to be positive, you need to confirm it with the diagnostic test, and it does not exclude other chromosomal problems. So next slide, ma'am. So what if it is a multiple gestation pregnancy or vanishing twin? So NIPT test has been validated only for twins, not the higher order multiple gestations. And in twins, higher fetal fraction is required. And in case the NIPT comes positive, in twins, positive testing requires invasive testing of both the sex. You need to do the CVS, you need to take the sample for karyotyping from both the sex, because NIPT does not tell you about the individual sac. And in case of a vanishing twin, at least 8 to 10 weeks of interval is required to go for a NIPT test, because most of the vanishing twins are caused by chromosomal anomalies. So it may come as false positive. So you should wait at least for 8 to 10 weeks. And these are the cost consideration. Look at the test. If we do only the contingent test and only the NIPT as a primary test, how much is the cost difference? That in a country like India cannot be accepted. So recently only, next slide please, ma'am. So recently only ACOG has recommended it as a primary test to for a detection of fetal aneuploidies. But is it applicable in India? Should it be applicable in India? No. In America, they are covered by insurance companies. But in India, it is to be done only as a primary test in high-risk patients only. Otherwise, only the contingent test is to be done. Still, it is a screening test. It gives information only about 5 chromosomes. And traditional testing, I tell you, if you go for a CVS directly, right, you will find information about all the chromosomes, and that too with a much lesser cost than NIPT. So please do not go NIPT universally. America has a very different healthcare setup, and ours is a very different healthcare setup. Next slide, please. So what would be the best way to screen? First, do a serum screening by a double marker testing. Do a anti-scan at 11 to 13 weeks. Calculate a combined risk. If it is a high risk, then go for invasive testing. And if it is a low risk, usual care is provided. Then where does this NIPT fall? It is only for very high risk patient. Only if there is a very positive family history, and for the intermediate risk patient as a contingent test. And if you find USG abnormality in second trimester, where this serum marker testing cannot be applied. But please do not do a NIPT test in a patient who herself is suffering from Down syndrome, because in her all the DNA would be of Down, so you would not be able to detect it by NIPT. For them, you will have to straight away go for a karyotyping testing or the invasive testing. So this is the comparison of various screening tests. I think we can skip this slide. So next slide, ma'am. So there is one more marker which is now offered in first trimester also, that is maternal serum alpha fetoprotein. Its high level basically are an indicator of neural tube defect, and it has now been included in first trimester penta screening. What does it do? It basically tells you about the possibility of development of FGR, stillbirth, and early onset preeclampsia. Then what if patient comes in second trimester? Very common scenario in our country. Then if she has a very strong family history, then go for a early anomaly scan. Then till 18 weeks, we can go for quadruple markers. And after that, only NIPT is to be used. NIPT, you can go directly for NIPT if there is a strong suspicion or on USG, or it is history based, or patient is very advanced age, like more than 40 years of age. And you need to do a target scan at around 20 to 22 weeks. So this was about the screening for fetal aneuploidies. What about other conditions? As I told, thalassemia, anemia, hypothyroidism, asymptomatic bacteria, GDM. We all are already doing it. I would only like to focus on the detection of this thalassemia and sickle cell anemia. So thalassemia can be very well screened with a good CBC and peripheral smear. We need to calculate the Menzer index. If it is low, it is more suspicious of thalassemia. If high, then the iron deficiency anemia. And if there is a suspicion, then only we go for the HPLC. But in cases, if the lady comes from a very high prevalence area, like from tribal area or from Sindhi community, then you need to go for HPLC straight away, because there the prevalence is very high. So you are justified to do in them, right? All other condition we are already doing. So I'll only take up preterm labor and hypertensive disorder in pregnancy in next few slides. So a few words about the hypertensive disorders in pregnancy. It is important to screen for hypertensive disorders in pregnancy because it is actually second leading cause of maternal deaths worldwide. At my place, it is first leading cause of maternal death. So FIGO also endorses the universal screening of HDP in all pregnancies, because first that by finding them at high risk of HDP, we can increase the surveillance and we can also start aspirin prophylaxis 150 mg HS daily, which has been proved to be very beneficial in preventing the development of hypertensive disorders in pregnancy. And then we have lots of history-based screening available, which is easy to adopt, and it has been recommended by all international agencies to apply this history-based screening to predict cases of HDP. We have our own Foxy-Gestosis score, which is very handy to use. We just need to download the app and it provides us about the risk of HDP. Then these are the high risk factors which have been mentioned by various international agencies. We all know about these factors. We just need to ask about these things from the patients. Then we can have this Gestosis app on our mobiles. As the patient comes, just check these things out and we have a score of 1, 2, 3. If the score is 3 or more by Gestosis scoring, patient is at high risk of having HDP. So you need to start the aspirin on time and you need to increase the surveillance as well. Next slide. So this is the sensitivity of different modalities. Actually, if we go only by the clinical screening or history-based screening, the detection rate is only about, the sensitivity is only about 34% for the preterm preeclampsia and 39% for the term preeclampsia. But if we combine biochemical test and the sonography, then you see the sensitivity, how it increases. The sensitivity increases to 75% for preterm preeclampsia. And if we use either of, like placental growth factor, which is the main biochemical marker, or the uterine artery PI, either of them if we do, then the sensitivity increases to 70%. So what we can do, if we do not have a placental growth factor with us to do, we can only add uterine artery PI to our routine NT scan. Then to repeat it with target scan also, because the false positivity of first trimester NT scan uterine artery PI is high, which reduces with second trimester target scan. So please keep in mind, we all are getting our NT scan and target scan done. Just go for a PI, uterine artery PI, especially in high risk patients who are high risk by history based screening. So this is the sensitivity if we use all the markers. Look at the sensitivity if we use PLGF, PEPE, uterine artery PI and mean arterial pressure. The detection rate is up to 100%. Can you imagine it? We can prevent this disease up to a great extent if we start including all these markers. But we can at least go for history-based screening, mean arterial pressure and uterine artery PI. These are the bare minimum we can do for these patients. Next slide, please. So we also have an international calculator with us, which is Fetal Medicine Foundation calculator. This is also an app-based calculator. Here you can only put your, reports values, uterine artery PI, PLGF value, gestation of the lady, and the PAPE values, and it will give you the idea what is the patient's risk of developing hypertensive disorders in pregnancy. Next, please. Then after hypertensive disorders of pregnancy, we come to the preterm labor. We all know that it is a major problem in India. The incidence is up to 15%. So the ultrasound USG based cervical length is the main modality to screen for preterm labor. We can include it as a routine screening method with a target scan for all population and anti-scan in high risk group. So if a lady come to you in first trimester, you can always do a cervical length along with your anti-scan if she is a high risk patient by history. And if she is a routine patient, you can include the cervical length in your target scan. Mind it, it is always to be measured by TVS, and we have progesterone medicine, a very magical medicine to prevent this preterm labor to a great extent if started timely. We also have a history-based encirclage and USG-based encirclage if we keep on doing this USG cervical length serially in cases of lower length, lower than the 2.5 centimeters. Then we need to do serial USGs to look for the cervical length. Next, please. Apart from this USG, history also can give you a great clue about the possibility of developing preterm labor. There are modifiable risk factors, there are non-modifiable risk factors, which we can ask from the patient. There is a score called as Paperniak score, from which we can calculate the risk of these patients. And on the basis of risk, if patient turns out to be high risk, we can go for the cervical length measurement right from our anti-scan USG. And if she's a low risk, we can do this cervical length measurement at target scan time. Other thing is per speculum examination and vaginal examination that has also been offered as a screening method for preterm labor. Then in biochemical markers, which are not much used because they are not available also, it is the fetal fibronectin testing. Basically, other two are not available at most of the places. So basically, it is the history-based screening and the ultrasound cervical length measurement, which is to be used to predict preterm labor. So this is how we combine our test for early pregnancy screening at the base of the pyramid, at the upper part of the pyramid. We take a proper history, do a proper examination, we do some blood tests, we take a mean arterial pressure, we do a good ultrasound, and then on the basis of the results, we divide the patients into two groups, high risk and low risk. High risk will require a close monitoring and low risk will go for a usual antenatal care. So to summarize, inverted pyramid of antenatal care should be adopted by all obstetricians to achieve optimum outcome. First trimester is the best time for screening the most common problems. Combined first trimester screening should be offered to all antenatal patients. Anti-scan could be of great help other than the screening for aneuploidies. A proper pre-test counseling is a must in all cases, and NIPT has its own limitations, therefore should be used with caution. Thank you so much for your patient listening. It was a vast topic. I tried to cover it on time. Thank you.
Wonderful deliberation, Dr. Binu Kushwaha. And I'm happy to know that you are also a GRMCN.
Oh, ma'am, you are also a GRMCN.
Yeah.
Which batch, ma'am?
89 batch, and I'm a 89 batch and did MS as well from the same institution.
Oh, wow, ma'am. Great to know you.
Yeah, same here. And one thing which is very catchy that you said in NIPT, it is high efficiency screening test, not at all a diagnostic, which we need to tell to our patients. So the importance of counseling is very much there. And about that, can you elaborate a little bit about spontaneous chromosomal problems at de novo chromosomal problems in a fetus, which we can't screen that way?
Yeah, actually, there are many chromosomal problems. We cannot detect for everything. We cannot detect everything. In a screening program, we need to detect only those which are of high prevalence, like aneuploidy. So
Right.
that needs to be told to the patient that other than these aneuploidies, there are multiple other chromosomal problems that may occur spontaneously and that cannot be detected by routine screening, and that needs to be screened only if there is a like family history positive. We cannot detect for the spontaneously happening chromosomal problems which are occurring de
Right.
novo. That can only be detected if there is a suspicion on ultrasound. Then we can go for CMA, like karyotyping and CMA, but we just cannot detect all problems all the times.
So as far as NIPT is concerned,
Ji, sir.
pre-counseling and post-counseling, I mean post-test
Ji,
counseling is equally important.
ji, sir.
Before advising test, you have to
A
counsel.
patient has a scan, they assume कि इनने सब देख लिया.
Yes.
They
Yes,
actually
yes.
don't believe that
That's the problem.
you are missing something or
Yes.
you cannot see everything. So that counseling is, it's the key.
So
And
pre,
most gynecologists don't really have time for that. So,
Ji, ma'am.
Dr. Beenu,
Jyoti?
congratulations. I want to ask one question if
Ji, ma'am.
it's
Ji.
allowed. Like the case, I will not ask the preterm labor and HDP, but like
Ji,
in
ma'am.
here, sickle cell anemia is very, very common. And I have
Ji,
one
ma'am.
patient of sickle cell trait, husband and wife both. So in that condition, what will be your advice? Like in the last pregnancy, in the second trimester, we need to go for the amniocentesis and baby came out to be sickle cell disease. So this time again, she is pregnant 6 weeks now. So what will be your approach for this patient?
Ma'am, as first trimester MTP is much easier, I would tell that we should go for CVS in these patients. In MP, ma'am, in tribal areas, which is at Chhattisgarh border, they
Yes.
have come up with a program actually. They are screening all the sickle cell trait couples, and then they are offering them CVS at free of cost at fetal medicine centers. So the pregnancies can be terminated early. So I would say that
Rather than the other soft markers and all, because they are not very 100%. They cannot diagnose 100% this thing. So CVS will be the choice for this.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Thank you. Thank you,
Right.
Doctor.
Thank you, ma'am.
As far as sickle cell problem is concerned, not only prevalent in some district of MP, but it is prevalent in some district of Gujarat also, which is nearby MP. And so many cases are being treated at Varda. They had a very good paper as far as this sickle cell and thalassemia patients from
Ji.
Gujarat and some part of MP and some part of Maharashtra. And
Ji.
Devli Sawangi, Dr.
Sir, I
Surekha
will
Taide,
say
and
that the caste which are in which it is very common, we should directly go for even for HPLC, because this couple was not knowing. They were saying कि हमारा sickling हुआ है and we are negative. But when I have given them a chance to go in HPLC, both were sickle cell trait and the baby on the amniocentesis was sickle cell disease.
And
Ji,
after delivery or
Thank you,
particularly
sir.
after cesarean section, in few of the cases, sickle cell crisis is also known. So it is to be kept in mind when we are counseling with patient of sickle cell, then we should advise for that also.
Ji.
Sir, Tripti Didi, Abha Singh ma'am and Sarita are still there if they want to say something.
Yes. Let us have comments from them.
Right, because we are very much in an area where the sickle cell is very, very good, highly prevalent. So this is a common theme that the most of the patients, even after cesarean section, during pregnancy also, they come with the sickle cell crisis status, and many of them, they might have received, very recently we had one patient who has received as many as 14 blood transfusions, and she was, because of the such a large number of the blood transfusions, she was having even minor Brooks complications. So these patients, they are really very important to be taken care of, and particularly if she is SS and the husband is Yes, we have to have this test, these tests to be done because the patients are more likely to have the offspring with sickle cell disease. And we know the patients, the babies who are suffering from the sickle cell disease and how bad they do during the early childhood if not properly taken care of. So, in such patients, rightly said that the CVS may be one of the options which must be offered to them so as the neonatal and the early childhood problems can be avoided. So, rightly said.
Yes, and
Thank
I
you,
totally
Tripti Di.
agree
And
with.
Sarita, you want to add something?
Yeah, I totally agree with Dr. Tripti Madam's comments and all. But what I see in my practice, we are getting many patients who have done the sickle cell positive, but they don't know they are trait or they are the homozygous. In that case, they manifest suddenly with a great problem. We're not able to save even the babies and the mothers on that day. So I still feel that doing an HPLC is a good job. It is going to be much more cost effective in the state like Chhattisgarh. So we do opt routinely getting an HPLC because if you do a sickling test, it comes up to be positive, then again you have to get it done whether it's a trait or it is this disease, and then you get a partner test in Jung. So if it is a trait and the partner test is negative, then in that case you can still avoid doing this because we are concerned with the disease part. We are not more worried about the trait part because just we're not going to terminate the pregnancy in view of the trait. So that is one thing I wanted to point. The second thing, we are like most of the time it happens you get a double, your combined screening positive or something and you advise for the CVS. And such time it comes like that in the CVS, what tests you're going to offer for karyotyping, qPCR, microarrow, gene sequencing, and on based upon the history also. So I think it is at most important that each and every obstetrician must know about this basic test, when and which test. Simply sending the patient get an CVS done is not an answer. We must
Yes.
have what answer I want, that should be very clear in my mind when I'm referring this patient for a CVS or the that's all. Thank you. Excellent talk, Dr. Binu. Really
Thank you, ma'am.
great
Thank
applause to you for the crisp information.
you, ma'am.
Sarita.
Thank you.
Thank you, Jyoti. Thank you, Dr. Sangeeta Sharma, and thank you, Binu.
Thank you, ma'am. Thank you.
So you really did a hard
Thank you
job.
so much, ma'am and sir, for providing me this opportunity.
Thank you.
I'm feeling privileged. Thank you so much.
Yes.
So may we start the
Oh,
panel
yes.
now?
Oh, yes. Oh, yes.
So welcome to this much awaited panel on PCPNDT Act. We have our expert, Dr. MC Patel sir, and I will be coordinating it. And dear friends, if somebody is not present here, I would request any other panelists to please take up the question, which I would actually be displaying. So, because these questions, the way it has been structured, we are going to cover the entire act, and then if there are any questions left, we can take them at the end. So I would like to introduce MC Patel sir. Not that he needs an introduction, he's been to Raipur so many times, and he had one whole day on PCPND Act with us in Raipur. He is a consultant obstetrician, gynecologist, and medical legal counselor, vice president FOXI in 2018, organizing secretary ICOG 2017. He was the chairperson of Ethics and Medical Legal Committee FOXI 2011 to 13, honorary secretary, state SOGO, organizing chairperson MMCon 2018, honorary member, National Inspection and Monitoring Committee, PNDT Act, Government of India 2015, honorary member of State Supervisory Board, PNDT Committee, Gujarat, President Ahmedabad Society 2010-11, honorary member, National Managing Body, Indian Red Cross Society, National President, National Medicos Association, President IMA Ahmedabad, honorary surgeon, Indian Red Cross Eye Bank. More than this, I would like to tell you that he does a lot of work for the tribes in the Northeast. He goes every year for treatment of people and he knows everyone. That's me. I'm the coordinator here. And these are our panelists. I will be introducing them as the questions come along. So welcome, respected panelists. And I would now, here is an appeal from MC Patel, sir.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together on this auspicious day with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So, sir, before anybody else asks question, I would like to introduce the topic by a few basic questions. What exactly was the need of the PCPNDT Act?
So in census of 1971, then census of 1981, and then census of 1991, it was observed that sex ratio of 0 to 6 years of children, male to female, were deteriorating at very fast rate. And for that, in 1994, this act was enacted, PNDT Act, Prenatal Diagnostic Test 1994, Regulation and Prevention of Misuse. But even in spite of this act enacted in 1991, again in census of 2001, the ratio in 1991 was 1,000 male children to 945 female children. It was still deteriorated from 945 to 928. So there was public interest litigation in 2003 that in spite of this act enacted in 1994, in census of 212, still ratio is getting deteriorated. So preconceptional sex selection was added in this PNDT Act. So now it is called PC-PNDT Act 1994. So this is the real genesis of this act, how this act came into existence.
Thank you, sir. Thank you, sir. So it came into force in 1991.
1994 and amended in 2003. Of course, thereafter there was amendment in 2012, 2014. So some new amendment came, but major act, it was enacted in 1994 and major amendment in 2003, where preconceptional sex selection was added, and now it is
so
called
that is the next question. That is the next question. Sir, so now we have Dr. Nidhi Bajaj with us. So she is the secretary of Katni Obstetric Gynec Society, and these are rangolis that she has made.
Thank you, sir.
And you'll be surprised, sir, that she loves painting and rangoli, and also she's a district level badminton player. See these paintings. this artwork that she has made. So welcome, Dr. Nidhi.
Thank you, Asha Jain ma'am. Good evening, sir, and all the respected panelists and all of you present over here. I am Dr. Nidhi Bajaj, and I am a secretary right now at Katni Obstetrics and Gynec Society. I am highly obliged to Dr. Patel sir and Dr. Asha ma'am for including us in this auspicious panel. My first question to sir is, sir, which are the major amendments in PCPNDT Act, and what is the seriousness of this act? I mean, how serious this act has to be taken by a gynecologist who all are doing these sonographies and other genetic testings?
As such, any machine which is potential of sex determination is under PCPNDT Act. So even say, for example, surgeon or urologist or even cardiologist, they are also having machine, and all these machine are potential of sex determination. So they are also under this PCPNDT Act, but they are exempted from sending reports. Say, for example, if it is a echo machine and they are doing cardiology part only, then they will be exempted from the report sending every month and etc. But they are covered in this PCPNDT Act. As far as major amendment, just I mentioned in 2003 it came. So in spite of this act enacted in 1994, in census of 2001, again it was deterioration of the ratio. So preconceptional sex selection was added in this act, and one amendment came in 2012 and 2014 also. So and it was related to mobile this sonography unit. So in tribal area or in hilly area where mobile sonography machines are sent for diagnosis, etc., then they were separately registered. That ambulance one is registered under PCPNDT Act with all the details of machine in that one. But for that, machine cannot be taken out from that ambulance one, and patient should be examined in that one only. Was the amendment came in 2003 and then after in 2012. So it was for hilly area, tribal area where regular sonography facilities are not available, and mobile units are allowed to cater their services in this area. So these were some amendment came in those days.
Sir, what about the ART techniques and the IUI procedures are being included in the PCPNDT? And
as such, any procedure which is potential to go for determination of sex or preconceptional sex selection, they are under PCPNDT Act. As far as any activity related to ART, say for example, follicular study. The follicular study doesn't have potential to go for determination of sex. So it doesn't come in purview of PCPNDT Act. So as far as follicular study is concerned, no form is to be filled. But in other procedure where there is a possibility, then in this forms are to be filled.
Thank you, sir.
Yes.
Now we have Dr. Vandana Gupta. She is the president of Katni Society, and these are her pictures from Figo. She's just returned from Katni, from Figo.
Figo.
So she loves traveling and capturing those moments. Over to you, Vandana ma'am.
Good evening, sir. Good evening, madam. And thank you, madam, for doing this webinar. So
Dr. Vandana, please come closer to the mic. Yeah, please come closer.
My question is, which are the common reasons for feeling of
So, common reason for sealing of sonography machine and suspension or cancellation of register, usually they go with record keeping and filling up the forms. There is inaccuracy in record or inaccuracy in filling up the forms are the main reason. Of course, they go with some trap also, sending a fake patient, and patient asks for determination And if any doctor entertains patient's demand and there is a raid and a case are filed. But in usual scenario, we have seen common reasons. Say, for example, in Form F, name of patient is not written fully, address is incomplete or not written at all, telephone number is not written, detail about children, how many children she has, how many female, how many male, it is not mentioned properly, LMP is not written. So this kind of some discrepancy in record or in filling up the forms are the common reason for sealing of sonography machine. As far as the record part is concerned, one register is to be maintained under Rule 9, Sub-Rule 1 with only 4 columns: serial number, name and address of patient, name of spouse or father, and date on which patient reported for that very test, sonography or any other test. So if there is not proper maintaining of this record or that register, many times sonography is done and form is not filled up, or there is no entry in that PNDT register. So these are some common reasons for sealing of sonography machine and suspension or cancellation of registration.
Thank you, sir. Now, this is a garden of Padma Shukla, ma'am. She's the president of Riva Society. She is traveling right now, sir. So she's going to Indore. She has probably not been able to get. So Dr. Rekha, would you take this question?
Anybody from Riva can take.
Good evening, sir.
Yes, welcome.
Who is registered in TCPNDT Act?
So it is very important question whether place is registered, whether doctor is registered, or sonography machine is registered.
Yes,
As
sir.
such, according to law, place is registered. And in that very place, whichever number of doctors are working, they are enrolled. Say, for example, 10 doctors are working at that very multi-speciality hospital as a sonologist, then all the details of those doctors is to be mentioned at the time of applying for the registration. But place is registered. And all the sonography machine in one center, there could be n number of machines. So all the details of machine are also to be given to appropriate authority at the time of applying for registration.
Yes. Which are the provisions for registration, sir? Which columns have to be ticked?
So it depends upon your practice. If you are going to go for non-invasive practice or invasive practice, if you are going for non-invasive practice only, that is sonography center. So you can go with either genetic counseling center or genetic laboratory or genetic clinic and or sonography center. But if you are going to go for invasive procedure like amniocentesis, chorion villus sampling, fetoscopy, fetal sampling, then at the time of applying for registration for genetic clinic, you have to mention everything in Form A, that which kind of facility you should be allowed to conduct.
Thank you, sir.
Sir, here there is one problem in Raipur.
Yes.
They are asking everyone with an ultrasound machine to register as a genetic counseling center. Is that as per law or not?
No. As such, it is a wrong interpretation on part of appropriate authority, how they interprets. Say, for example, if it is a case of spina bifida and hydrocephalus or any other. So in this type of situation, many times you will advise termination of pregnancy. Patient will be terminated with taking all the care and caution. But now very important question on part of patient and patient party would be, doctor, can it be repeated or will it happen again? And when you have to counsel for that. So appropriate authority interprets that it is a genetic counseling. And for that, they insist that each and every center who counsel patient for genetic area should be registered as a genetic counseling center. As such, it is not required if your center is registered as a genetic clinic. And just I mentioned prior also, if you have asked for all these procedure, amniocentesis, chorion villus sampling, fetoscopy, fetal scalp sampling, etc., then it includes all. So if your center is
No, sir. If it is only ultrasound, then does it have to be registered as a counseling center?
As such, according to law, no. But many a time appropriate authority interprets in their own way, and not to end up into any dispute with them or to be end up into litigation, we have to follow their instruction. Otherwise, as per law, it is not required. Because say, for example, for radiologist friend, they are only doing sonography. They are not at all going to advise anything. They will simply go for screening and they will submit the report, and report will be sent to person who have referred the patient, and that person, so gynecologist also, he will interpret report and advise patient accordingly. So in this case, there is no counseling of patient on part of radiologist. They are submitting only reports. So this is interpretation on part of appropriate authority wrongly.
Okay. So now we have Dr. Rekha Singhal. You know, she told me that she is interested in everything extracurricular: gardening, cooking, singing, bhajan, art and craft. And these are all samples of her craft. So she's already asked Dr. Padma's question, but so much of art between gynecologists. So Dr. Rekha, over to you. And
thank you.
I forgot to tell that she's also the secretary of Riva Society. I got carried away.
Okay. My first question is, sir, what is the procedure for applying registration in PCPNDT Act, and how much fees to be paid?
So when you have to apply for registration under PCPNDT Act, there is a prescribed form, that is Form A. And in that very Form A, you have to apply all the columns. It is very simple column. So with all details, you have to apply in Form A. And as far as fee part is concerned, so if it is a single unit, say for example, genetic clinic or sonography center or so, then fee is 25,000. And if more than one category is applied for, say for example, genetic clinic as well as genetic counseling center, then in these cases, and when it is multi-speciality hospital, then in that very case, fee is 35,000.
So is there any precautions to be taken at the time of application?
Yes, I mentioned little prior also, at the time of applying for registration, you should specify which kind of facility you require under PCPNDT Act. If you are going to go for invasive procedure also in future, then you have to mention in Form A, and they will allow accordingly. So in your form, when registration is granted, in that very form, it will be mentioned that you are allowed to conduct invasive procedure also.
So could it be applied physically or only online?
So as such, previously it was in physical form, but now in so many states, it has become compulsory to go with online only. So we have to apply online, and once application is granted, then only we have to pay for fees.
Sir, once the center is registered, for how much period is?
It is registered for 5 years. 5 years.
Okay.
From date of application. Once, from date of registration. Once your application is granted, registration is given, then from that very date, you will be registered for 5 years.
Yes, sir, one more question I want to ask. See, somehow machine is locked, our machine is locked, and we have registration, for and again we want to start our new machine. Then if we require new registration?
No.
Yes.
just I mentioned place is registered. Once your place is registered, once your place is given registration of, I mean, certification for registration, then
Okay.
you can buy machine, you can sell machine also, but it is very much necessary that you can sell machine to registered center only, and you can buy machine from standard company, and 30 days prior of installation of your machine, you will have to inform appropriate authority.
Okay, got it. Thank you, sir.
Yes.
So that is Tabassum, sir,
Yes.
president of Raipur Society, and she loves adventure sports. I've worked with her for so many years and I didn't know she loves adventure sports.
Yes.
So over to you, Tabassum.
Thank you, Asha Didi. And good evening, sir. Honored to be with you in this panel today. My question is, who is sonologist in PCPNDT Act? Who can do the sonography?
So this very question was raised in Supreme Court in one of the cases, and Supreme Court referred that very question to Union Health Ministry, and Union Health Ministry referred that very case to Medical Council of India. I am talking of 2012. And in meeting of Medical Council of India, which held in 2012, it was very specifically mentioned that any postgraduate degree, diploma or DNB holder in OBGYN or in radiology are sonologists. One, any teacher in radiology or in OBGYN in medical college are sonologists. Any MBBS qualified person who is registered in a state council and who has taken training, prescribed training as per PCPNDT Act, and who has passed the examination, then he is also sonologist. So these are the categories who can be considered as sonologists. And when MCI came with this clarification, it was considered in Central Supervisory Board meeting of PCPNDT Act, and in Supreme Court, this answer was given in 2014.
Okay, thank you, sir. And this is another question I would like to ask is, as we discussed that our appropriate authorities are saying that we should register for genetic counseling center. So my question is, they are saying to pay the fees again. So the people who have recently registered need to pay it again, the 30,000 or 70,000?
No. Once your place is registered, you can have N number of machine in that very center, and N number of sonologists can work in that very center. No separate registration for each machine, no separate registration for each person. Place is registered.
Sir,
Okay.
what Tabassum is asking is, sir,
to
change the type, which column to be ticked, right? It was only
Yes, yes.
ultrasound. Now they are insisting on genetic.
No.
Counseling center.
There is provision in Rule 13. If it is a change of place, change of employee, change of machine, simply you have to intimate, not permission even, intimation, but 30 days in prior. Say for
No,
example,
sir. It is the service is changing. The service is changing.
No. Change in employee, change in machine, and change in address.
Not that, sir. Not that. The service is changing, no? From plain ultrasound to genetic counseling.
From imaging to
So
genetic counseling.
category, no. So it is change of category.
Yes.
From
Yes.
genetic counseling center to genetic clinic or genetic.
From imaging to genetic counseling center.
Yes. So in this, it depends upon the appropriate authority to interpret, but many of appropriate authority are kind enough, without taking fee further, they change the category. Or many a times some appropriate authority will ask you to go with new registration formality and to have a new registration. But it is again depends upon the interpretation on part of appropriate authority. It is again gray area, and there is no specification in law also.
Sir, who is the central appropriate authority?
So there are three-tier system as far as this PCPNDT part is concerned. Immediate is district appropriate authority, and above that district appropriate authority, state supervisory board and state appropriate authority, and above that central supervisory board and central appropriate authority. So this is three-tier system as far as regulation of this act is concerned.
So how to approach the central appropriate authority regarding this matter?
So, nahin, if you are aggrieved with decision, only 1 minute. If you are aggrieved with decision of a district appropriate authority, then you will have to approach state appropriate authority, preferring appeal before state appropriate authority. But if it is a union territory, then in union territory you will have to go to central ministry straightway because they are under central ministry. If you are aggrieved with decision of state appropriate authority, then you will prefer appeal in central supervisory board, that is central appropriate authority or central government. And there is judicial remedy available also. If you are not to go to that track, you can go for writ petition in Honorable High Court challenging decision of any appropriate authority.
Okay. All
There
right,
are
sir.
two ways to go.
Okay.
It is under section.
I have a question. Hello.
Wait.
Good evening, sir. I have a question. Like a sonography, how many centers a sonography sonologist can perform?
Dr. Rashmi, we will come to that question.
Sure.
Hold on. And Tabassum, Monica hasn't logged in, so would you ask her questions as well?
Sure, ma'am. Sure.
So Dr. Monica Pathak is the secretary of Raipur Society. She loves dancing, but she's not here right now. So over to you, Tabassum, to ask the questions.
Sir, Monica madam's question is, can appropriate authority reject application for registration in PCPNDT Act?
Yes, appropriate authority can reject, but again, there is a provision in PCPNDT Act. Appropriate authority will have to give reason in writing in Form C, that is prescribed form. Prescribed Form C, why this application is being rejected. And if you can solve that query, then you have no need to go for fresh application or no need to go for fresh fees also. But there is a time limit given. So in that very time limit, you should solve the query if at all application is rejected for a given reason in writing.
Yes. So which are the provisions?
The same I explained.
You told already. Which are the provisions about renewal of registration?
So again, the same procedure when we apply for registration in Form A, at the time of renewal also we have to apply in Form A. In most of the states now it is online. So when your registration is getting expired, so before 30 days of expiry date, you have to go for application of renewal in the same procedure in Form A. But in this renewal, fees to be paid is half. If your center is single center and if you have paid 25,000 at the time of registration, then at the time of renewal, you will have to give only 12,500. If your center is multiple centers, and if you have paid fees of 35,000, then at the time of renewal, you will have to pay 17,500 rupees.
All right, sir. And is there any provision of deemed renewal?
Yes. So at the time of applying for renewal, once you have applied for renewal, and if appropriate authority doesn't communicate you within 90 days, 90 days, your center is deemed renewed. Automatically it is renewed and you can do sonography practice. So appropriate authority is under obligation to respond your application for renewal within 90 days. And if it doesn't, then your center is automatically renewed.
Okay, right. Thank you so much, sir.
But here, word of caution. Just I mentioned that at the time of renewal, you will have to apply 30 days prior. So say for example, you have applied 30 days prior and today is last day. And next day, tomorrow only your center is no longer registered. So you cannot practice sonography because appropriate authority has 90 days to respond. So I always advise our Foxian friends at the time of renewal, apply 90 days prior. Not 30 days prior, 90 days prior apply for renewal. So if at all appropriate authority doesn't turn up within 90 days, your center is automatically renewed.
Sir, one more thing I wanted to ask
Yes.
here was that, we were talking about who can do practice, who is a sonologist. Now, MP High Court has given an order that a gynecologist doing ultrasound cannot give a report. They are not considered sonologists.
No. This is a wrong interpretation on part of High Court also. It can be challenged in higher fora, but it
has not been challenged, and till then, does it hold that a gynecologist cannot do ultrasound?
No. Gynecologists very well do, and I have all the minutes of that very meeting just I mentioned prior, which happened in 2012 at MCI level. I have minutes who attended that very meeting and what was the decision. And same way, Central Supervisory Board's meeting, which held in 2014, I have minutes of that meeting also. And as far as PCPNDT part is concerned, Central Supervisory Board is the highest authority as far as implementation of PCPNDT Act is concerned. And once it is passed by Central Supervisory Board, it cannot be challenged.
Sir, one more thing. You said that the fees has to be paid after they accept it. But in our place, the form is online. The fees has to be submitted first. Then you take a printout and then you go and submit it. That is how it is done.
So there would be software in your state, but otherwise in Gujarat, software is like this. Once your application is uplink, then next question will become, your application is uplink, now you can go with fees and you have to go for fees.
So, sir, we
it
have
depends upon software.
Dr. Rashmi Sharma, the president of Bilaspur Society with us. And she loves traveling. And you can see the background that she has here. Beautiful. So, Dr. Rashmi, if you could say where this is. You're muted. You're muted.
Please
This is in Germany, Cologne, the biggest church you can say, and the oldest church of Europe. So I visited this last week only. Unfortunately, I was not there in Figo. I had visited my daughter's place. She is there in Amsterdam studying. So I was there. So thanks, Dr. Asha and Dr. MC Patel, sir, for inviting me for this PCPNDT panel.
Welcome.
And the best part is that we don't have to answer. We have to question you. So this is the best part of this panel. And this is very informative. So my question to you, sir, is which are the provisions for public information in PCPNDT Act?
So it is mentioned in Rule 17 as far as this public information part is concerned. So starting from once your center is registered, you are given a certificate of registration, that is Form B. So one copy of that Form B is to be displayed at conspicuous place of your business. So in waiting room or so. And one board. In that very board, size is also recommended in few of the states. Say for example, in Gujarat, it is 3x2 with a blue background and a white font. So name of hospital, address of hospital, and writing like this: prenatal sex determination is criminal offense and punishable offense, and this type of determination is not done here. So this type of board is also to be displayed at conspicuous place of business. One more area as far as public information part is concerned, copy of bare act of PCPNDT Act should be available in that very clinic which is registered under PCPNDT Act, and it is for perusal of any visitor. Any visitor of your hospital can ask for the copy of PCPNDT Act. So you should have a latest copy of PCPNDT Act with you. So displaying Form B, displaying board, and copy of PCPNDT Act. These are some provision under Rule 17 as far as public information part is concerned.
Okay. So the next question is, which are the provisions for punishment?
So as far as punishment is concerned in PCPNDT Act, there are two categories. Both are punishable. Person who is doing sex determination and patient who is undergoing sex determination. So if it is very first time as far as patient part is concerned, then 3 years of imprisonment with fine of rupees 50,000, and second time 5 years of imprisonment and fine of rupees 1 lakh. As far as person doing sonography, imprisonment for 3 years and fine of rupees 10,000, and for second time imprisonment for 5 years and fine of rupees 50,000. And one more provision, these all provisions are in section 23. So in one provision is also there. When there is no specification of punishment is mentioned, that in this type of situation, punishment for 6 months to 1 year and fine of rupees 10,000 can be awarded. And one very dangerous clause as far as punishment part is concerned, as soon as any charge sheet is filed against any person, appropriate authority shall, here word shall is used, appropriate authority shall inform medical council of respective state to take necessary action, including suspension of registration. So once charge sheet is filed against you, appropriate authority will write to medical council of your state, and medical council may take decision to suspend your medical registration also. So from that very day, you are no longer a doctor till your case is finalized. So this is very dangerous provision in this act, that is section 23 of PCPNDT Act.
Very important information. Thank you, sir. Thank you, sir, for your valuable information.
Thank you, sir. And this is Dr. Kirti Kaura, the secretary of Belai Society, and this is her garden. So she loves gardening, and you can see how luxurious it is. So over to you, Dr. Kirti.
Good evening, ma'am. Good evening, all of you. First of all, I would like to thank you, Patel sir and Asha Jain ma'am, for involving me in this program. Happy Navratri to all of you. Sir, I would like to ask you, what is the importance of maintaining of record for PCPNDT Act?
Because merely on ground of inaccuracy in record or inaccuracy in form, appropriate authority will serve you a notice why your center is not to be suspended. I mean, registration is not to be suspended, and your machine can also be sealed on the ground of inaccuracy in record. And under section 4, subsection 3, it is very specifically mentioned, any inaccuracy of record will invite a contravention of section 5 and 6 unless contrary is proved by person doing sonography. So many a time in few of the cases, it is interpreted on part of honorable courts also that inaccuracy in record or inaccuracy in filling up the form is also a crime under section 4, subsection 3. And in few of the cases, punishment of imprisonment from 6 months to 1 year is awarded to few of our Foxian friends. So to maintain record is very much important, and you have to maintain record very precisely.
Sir, my next question is, which register is to be maintained under PCPNDT Act?
Only one register is to be maintained as far as PCPNDT part is concerned, and it is mentioned in Rule 9, Sub-Rule 1. Just I mentioned prior also, register only with 4 columns: serial number, name and address of patient, name of spouse or father, and date on which patient first subjected for that test. So with these 4 columns, you have to maintain that registered under Rule 9 Sub Rule 1.
Thank you, sir, for giving such a elaborate information on this.
Roten खिला दो. So next we have Dr. Jagrati Nagar with us, sir. So she loves writing poetry and gardening. She hasn't been able to send me photographs, but Dr. Jagrati, over to you.
Thank you so much, ma'am. First of all, I would like to thank you, respected Dr. MC Patel sir and Dr. Asha Jain madam, for making me part of this prestigious webinar, Happy Learning, and Subh Navratri to everyone. My question is, sir, which are different forms to be maintained under PCPNDT Act, and what is declaration on part of the patient and doctor?
So as far as different forms are concerned, it depends upon the category of your center registered. If your center is registered as a genetic counseling center, then you have to go for Form D. If your center is registered as a genetic laboratory, then you have to go for Form E. If your center is registered as a genetic clinic or sonography center, then you have to go for Form F. And for invasive procedure, Form G, you have to go for Form G if you are going to go for any invasive procedure. And as far as declaration is concerned, declaration on part of patient as well as on part of doctor, it is a part of your form only in section D. So declaration on part of patient will give declaration that I am not at all interested to know sex of my baby. That way she is going to give declaration, and same way doctor will give declaration that doing sonography, neither I have seen sex of fetus nor I have declared sex of fetus to anybody. So this is declaration on part of patient as well as on part of doctor.
And my next question is, sir, what is about consent of patient?
So under section 5 and subsection 1, it is mentioned about consent of patient. But particularly when you are going to go for invasive procedure, then you have to go for Form G. And in that very Form G, consent of patient is taken. So it is very specifically mentioned that I had been explained about all the after effects and side effects of the procedure. And after understanding, I have given consent to go for this procedure. And if my report comes normal, I am not going to terminate my pregnancy. So that kind of consent patient will give in Form G as far as invasive procedures are concerned.
Thank you so much, sir.
Asa, you are muted. Please unmute.
Oh, sorry.
Yes.
Dr. Taruna Sharma is the secretary of Sagar Society. I don't see her, sir. So, Dr. Jagrati, do you mind taking this question?
Sure, ma'am. Sir, how and for how much period records should be preserved for PCPNDT Act?
So as far as PCPNDT part is concerned, we have to preserve all the record related for 2 years. But in case of litigation, till final disposal of case, we have to preserve all those records.
Thank you so much, sir.
Sir, we have Dr. Mahesh Prasad, sir, the secretary of Singrauli Society. Again, I don't think he's here. So, Rashmi ma'am, would you take the question, please? Rashmi ma'am, you're muted.
Yes. So question is, what is provision of reporting monthly report in PCPNDT Act?
So as far as PCPNDT Act is concerned, there is a provision that at the end of month, you will have to report within 5 days. So in the next 5 days, you have to report appropriate authority about all the forms if you have gone for ultrasonography in antenatal patient. And if you have gone for any invasive procedure, then form G. So within 5 days, you have to go for. And in few of the states, there is a provision to submit online also. So in few of the states, there is a provision that online submission should be within 10 days. In few of the states, it is again for 5 days. So it depends upon the state where you are practicing. But online as well as physical, there is a provision under this PCPND Act for reporting.
If we miss that period, then?
Then they may serve you a notice, they may give a show cause notice, they can suspend your registration, they can seal your machine, they have all the powers. But if you can give valid reason for delay, and if they consider, it's fine. But it is at the discretion of appropriate authority. So it is always better to submit report well in time.
Okay. Thank you, sir.
Thank you, sir. Now we have Dr. Preena Shukla. She's from Bilaspur, loves doing fetal medicine, cooking, and loves music. So Preena, are you there? You're muted.
Yes, ma'am. Good evening, sir. Thank you, Asha ma'am. Sir, my
Thank you,
question
dear.
is, what are the provisions about intimation of change?
So there is a provision in Rule 13 as far as this intimation of change is concerned. So change of employee, change of machine, and change of place. If ownership is changed, then you will have to go for new application. Otherwise, simple intimation, no permission even. Say for example, if you are going to install one new machine, then you will have to intimate 30 days prior that you are going to install machine with following details. And once machine is installed, I will give information again. So once your machine is installed, you will give intimation that my machine is installed. This is not permission, it is intimation only. Same way change in employee. Say for example, one sonologist is visiting in your hospital and he is leaving job. Then you will have to intimate appropriate authority 30 days prior. But in many of the cases, he may not give you notice for 30 days and he will say that from tomorrow only I am not going to come. So as soon as you come to know that that very sonologist is not going to come in your hospital for his services, then you will have to intimate appropriate authority immediately that Dr. So-and-so is not going to give services as a sonologist in this very center. If you are employing new sonologist, then you will have to intimate 30 days prior. And after intimation, 30 days, then only that very sonologist is capable to do sonography in your center. There is a provision.
Sir, next question is, how many centers sonologists can visit in the same district under the Act?
So it was amended in 2012 and 14 that any registered sonologist can visit 2 centers in the same district. But that very decision was challenged in 5 different high courts. Say for example, in Hyderabad, in Karnataka, in Aurangabad, in Delhi. So, and in all those high court, it was stayed. So when this appeal was being heard at Honorable High Court of Delhi, so Delhi High Court wrote to Central Supervisory Board and central government that different 5 high courts are facing this appeal as far as visiting of center not more than 2, and all the high courts have stayed. So till final decisions come, please have a circular to all the appropriate authority as far as this part is concerned. So still final decision has not come and that order is stayed. So as on today, person can visit n number of centers in any respective district.
Thank you, sir. But sir, at our place, I have seen that permission is required for the change of machine also. I mean,
No,
it is
no.
not only intimation,
No,
they don't give permission for change.
Under Rule 13, it is mentioned intimation. No word permission is used. Intimation for change of place, change of machine, change of employee. You have to simply intimate 30 days prior. And you cannot be challenged legally also. Because once you have intimated, there is no provision of permission. It is wrong interpretation on part of appropriate authority.
Sir, here they are not allowing anyone to go to more than 2 centers.
So you should have a copy of that stay.
It is there, sir. It has been given to them. And they refuse to listen. कि नहीं होगा. That is it. हम center बंद करा देंगे.
So if society is interested, then society may appeal in a court that if they are not comply with the decision of Honorable High Court, then it is contempt of court. But it should be on part of society, not individual.
Okay. Okay. Sir, next question is from Dr. Prakriti Verma. Dr. Prakriti Verma from Bilaspur. Another person who loves singing and cooking. Dr. Prakriti, are you there?
Yeah, ma'am. Sure. Good evening.
Yes, welcome.
Yeah, thank you so much for providing me this opportunity. Sir, my
He is the
question is,
president
which are
of Chhattisgarh IFS, sir. Indian Fertility Society. So these
Yes,
things will interest her.
Welcome.
Thank you, sir. Which are the provisions about purchase, sale, and repair and permanent non-use of sonographic machine for PNDT Act?
So as far as purchase and sale is concerned, I mentioned little prior also. You will have to intimate appropriate authority 30 days prior that you are going to purchase machine with following details. As far as sale part is concerned, you can sell machine to registered center only. And you will have to intimate appropriate authority 30 days prior. So from your register form, that is form B, the detail of that very machine will be deleted. And when you are selling that machine, if it is same district, fine. It could be a different district also. So that appropriate authority will enter detail of that machine to that center where you have sold that sonography machine. So as far as purchase and sale is concerned is there. As far as repair is concerned, if it is repairable at your hospital level only, then engineer can repair your machine at your hospital level, it's fine. But if machine is to be shifted in workshop for repair, that in that very case, you will have to intimate appropriate authority that my machine is out of order and this is report of engineer that machine is to be shifted for repair. And after intimating appropriate authority in which vehicle you are going to transfer that machine to workshop with registration, I mean, a number of that very vehicle and copy of RC book you have to mention for that also. As far as permanent non-use of machine is concerned, you cannot straightway dispose of that very machine. You will have to intimate appropriate authority that my machine is totally out of order and it is not at all repairable. Appropriate authority will visit your hospital or he will send any representative delegating power, and that very fellow or appropriate authority himself will demolish that very machine. Because when it is in total non-use, you cannot give it buyback to the company or you cannot give it to Bangarwala. It is to be demolished in a proper way. So it cannot be misused by anybody in future is the purpose.
Okay. Thank you so much, sir. Very informative information.
And one more thing, if you are having only one machine and if it is totally out of order or it is not at all repairable, then in this case, not only intimation to the appropriate authority, but you will have to surrender your certificate also. Because once your machine is out of order permanently, and if you are going to demolish, then certificate is to be surrendered to appropriate authority. And when you buy new machine, that very certificate will be given back to you. There is one more provision.
Yeah. Sir, if we are having one machine in our premises, like if it is a multi-specialty hospital, so can we move the machine from from the sonography room to ICU or some other place?
Yes, you can utilize that very machine in the premises which is registered. Because here place is registered, you cannot take machine out of that premises. But in the same premises, in labor room, in ward, in OT, anywhere you can use machine in that very premises.
Okay, but here in Bilaspur, they sealed our machine because of this reason.
So this is wrong interpretation on part of again. And in this type of cases, whenever machines are sealed and they are challenging appropriate court, always decision has come in favor of doctors.
Yeah, that's very bad part. Actually, there are so much differences in the opinions of the appropriate authorities. Thank you so much, sir.
Thank you, Prakriti. And sir, we have Rashmi Budhia here, Dr. Rashmi Budhia. She is a person who is very much active, taking care of injured animals, cows, dogs, whatever. She even adopted a tiger and has been working for wildlife preservation a lot. She also works for a lot of NGOs, doing a lot of social work. So over to you, Dr. Rashmi from Bilaspur. More than that, she is a very dear friend.
Thank you, ma'am. Thank you so much. Thank you, sir. And thanks for making the part of this happy program. My question is, what is the, tell me about the power of appropriate authority to visit the clinic for inspection and seize records.
So under section 30, appropriate authority has all the power conferred to visit your hospital or registered clinic. But here word at appropriate time is used. So they can visit your clinic at appropriate time. At middle of night, they cannot visit. So at appropriate time, they can visit, they can inspect all the records. And if they found any discrepancy in record, then they can seize the record also. They have power confirmed.
Okay. So what is the provision of suspension and cancellation of registration of Center for PCPNDT Act?
So if appropriate authority has reason to believe that center is not working as per provision of PCPNDT Act, then under section 20, there are 3 subsections. So under section 20 subsection 1, they will issue a notice and notice will be served and they will ask for the clarification. And under section 20 subsection 2, opportunity of being heard is also given. So why your center's registration should not be suspended or cancelled, and you will be given appropriate time or appropriate opportunity for being heard. But there is one provision also under section 20 subsection 3. If it is in public interest, then section 20 subsection 1 and 2 can be omitted and straightway they can issue straightway take action. But in these cases, appropriate authority is under obligation to give reason in writing why this is a violation of public interest and why they have not served you a notice or opportunity of being heard is not given, and straightway action is being taken. So appropriate authority will have to justify their action also in court of law if at all we challenge their action.
Okay, sir. Thank you. One more question is there, sir.
Yes.
This act also include the as I have seen so many prescriptions with the patient file that some Ayurvedic medicines have written, and this can improve the fertility and the probability of birth of male child also. So does this act also includes the these types of prescription?
To enhance fertility, it's fine, but for selection of sex, any Ayurvedic or any Unani or even allopathic or any other method, they are not at all permitted under PCP Act. And if at all this kind of advertisement or prescription are found by appropriate authority, they have all the power to go for action.
Thank you, sir. Thank you so much.
Sir, Dr. Sangeeta Prasad, President Singrauli is not here. I would request any of the panelists present here to please take this question. Anyone can take it.
Okay, Asha, I'll read the question. Any provision under Act to challenge order of appropriate authority, sir?
Yes. So under section 21 and rule 19, we have all the power to challenge any order, any decision of appropriate authority. And there are two systems. So if it is order from sub-appropriate authority, we can challenge to appropriate authority. If it is from appropriate authority, then state appropriate authority, and then to central. And judicial remedy is also available in magistrate first class court, in sessions court, in high court, and even in Supreme Court also we can challenge. But there is a pyramid system, so we will go step by step.
And what about remedies in
That's the same,
PCP?
just I mentioned, you can have an appeal and in judicial remedy also.
Okay, okay.
Now the forum is open. I request everyone, please put on your videos. And if there are any questions that anyone wants to ask, any question, we can take those questions.
We will allow. Anybody have any question? We will allow any question. In chat box also they can write, otherwise they can raise hand and we will allow to ask.
Ma'am, we have discussed about the action against the doctor. What about the action against the patient who tell us to, who compel us to do for sex determination?
I mentioned prior also, there is a provision for punishment for patient also, and imprisonment for 3 years for first instance with fine of ₹50,000, and for second instance imprisonment for 5 years and fine of ₹1 lakh. But in that very case, there is one clause also. If it is proved that patient was compelled by relative of patient, family member, then patient will be excluded from the punishment, but then family member will be taken into consideration as far as punishment part is concerned. But usually we do not inform appropriate authority that that very patient had asked for determination of sex. In Gujarat, we had started in past, and in so many cases, notice were served to the patients also.
Okay, sir.
So
So
to
there is
whom the information should be given
Pardon?
if patient comes? So to whom the information should be
Appropriate
given?
authority.
DM.
Appropriate authority for PCP&DT Act is to be informed with all the details that patient with this address, etc., had been to me for sex determination. I have denied. Please follow, because if you have denied, then that very patient, if at all she is interested to go for determination, she will go to another place. So they can trace that very patient and they can find out any other person also who is doing sex determination.
Okay, sir. Thank you, sir.
Sir, one more question, sir.
Yes.
One patient came to my OPD and she was 18 years of age and she was having amenorrhea 2 months, and I diagnosed her as she is having, she might be having PCOD. But when I did her sonography, I found that she is having 8 weeks pregnancy. She was having, and she was minor. She was below 18 years of age. And when she got this, she immediately left the chamber, and we couldn't save. Although we couldn't save the picture, and we couldn't complete the record. And that situation was totally backed out. That how should I have managed that case?
But you have name and address of that very patient, because at the time of when you go for OPD case, at reception, then you will write the name of patient, age of patient, and address of patient. So in this type of situation, not even sonography, even from your clinical examination, if you have come to know that she is pregnant and she is minor, it becomes a case of POXO. And under POXO Act, you are under obligation to inform police in this type of situation. Even if patient has taken further treatment with you or not, doesn't matter. But when she is minor, when she is pregnant, it becomes a case of POXO and you have to inform police.
So, sir.
Okay.
So this is my humble appeal again to endorse my candidature for post of President Foxy election year 2024. If you consider my seniority, my sincerity, dedicated work in Foxy for years together, and readily available to deal with any situation with any of our Foxian friends in any odd situation, and if you feel that I can serve that association at higher position, then it is my humble appeal to endorse my candidature. Thank you very much.
Thank you, sir.
And
that's me.
on behalf of Asha Jain, I will appeal. She is going to go for chairperson, Food, Drugs and Surgical Equipment Committee, Foxy. She is since with me in this series since long. She is a hardworking person, you all know from your society only, Raipur. But she is very deserving candidate for this very post. So as far as nomination part is concerned, all the society will have to nominate candidature for Asha for this very post and my nomination for post of president. And at the time of voting in chairperson, society votes. So small society less than 100, 1 vote, more than 100, 2 votes, and society will vote. And some other voters are also there as far as chairperson's voting is concerned. So first you will have to nominate, and at the time of voting you will have to vote. So my humble appeal to nominate for both of us and vote for both of us. Thank you very much.
Thank you, Patel sir. And Singh ma'am, you are here till the end, so would you like to say something before I give my formal vote of thanks?
I just want to thank all the coordinators and everybody for a very wonderful evening. And I want to wish you as well as sir all the very best in your future ventures. And thanks a lot.
Thank you, ma'am. Thanks a lot.
So any question in chat box, Asha? Then we can.
Nahi hai, sir.
Nahi.
Nahi.
Okay, then we can conclude.
Sir, one question has come.
Yes.
What is the provision of preserving films of ultrasound pictures?
So as per this provision of
Preena has sent this question.
Yes.
So Preena, you could have asked.
Yes, no issue. We can cover. So under this provision of PCPNDT, we have to preserve all the records related to any sonography done to the patient. So plates, reports, everything we have to preserve. But many a time we have a habit to give plate to the patient. So in that very report, we will have mentioned that plate of sonography is given to the patient. But if you have provision to preserve in your machine, then in that very machine in hard disk, it will be there. And whenever it is asked by appropriate authority, you can have a copy from that machine also.
So what happens is when you take backup, sometimes the records get deleted.
If you have take backup, and then you have to preserve for 2 years at least. After 2 years, you are free to delete it. But for 2 years, you will have to preserve.
Thank you, sir.
Anyhow, it gets deleted from the machine itself. So is there any provision that we have to inform them? Or there are...
Yes, automatically, or for any reason, any virus or so, then you will have to intimate appropriate authority from this date to that date. Due to some reason, record from my machine is deleted. But if you have submitted all the forms of sonography done of those patients during that period, it is always with appropriate authority also, and one copy is with you also. But if you intimate, it shows your consent that you are complying with the provisions of PCPNDT Act.
Thank you, sir.
Thank you, sir. So thank you, Dr. MC Patel, sir, Chief Guest Abha Singh ma'am, guests of honor Tripti Didi and Dr. Sarita Agarwal, our experts, panelists, speaker, all the delegates and Corona Remedies, especially Tirth and Nilesh, for being with us in this program and facilitating everything. Thank you. Thanks a lot. I hope you have all enjoyed it as much as we have. And if anyone wants to say anything, otherwise, sir, we can proceed and end the session. Yes, Jyoti, you want to say something?
Thanks for making us medico-legally more sound, sir. And thanks for keeping the antenatal reverse pyramid talk. Both were very nice and they have enriched us. Thank you.
Okay,
And
we can
best wishes to both
Tirth
of you.
ji, you can end the session, please.
Okay, ma'am.
Namaskar,
Okay.
Shubh Ratri.
Yes,
Thank
ma'am.
you for
Shubh
being
Ratri.
here. नवरात्रि जाके सब गरबा करें जाके अब.
Thanks to Corona for supporting this educational and technical support, and Tirth and Nilesh in particular.
Thank you so much. Thank you so much, sir.
Welcome,
And
welcome.
thank you so much, ma'am.
Thank you.
So, okay, now I'm ending this session.
Oh, yes. Oh, yes.
Yes, please.
Okay, okay.
Good night, sir.